Go over the patient care framework for the rest of the training. We have discussed, I guess, quote unquote, the foundational stuff. So now let's get to work. So in your folders, you'll see this patient-centered practice transformation overview and process steps and patient journey. So let me orient you to this document so that way you can understand what we're doing. So we started off by thinking about the best way to walk you through the model in a way that makes sense to you, in a way that's more practical. So we thought about it that regardless of whether you're in the MD-PCP program or you're in another program, you show up on Monday and the patients start walking in the door. So it's still going to be that they check in, we prep them, we room them, physician consults with them, they check out, and any other follow-up activities. So why don't we use that as the baseline or the foundation and then layer the MD-PCP program over that? And it doesn't matter what any other program that you may be a part of. If you do it that way, it keeps you focused. You have a steady hand. So saying to me, instead of us looking at this and kind of saying, okay, this is a program and we have to check this requirement, check that requirement, and running around like a chicken with his head cut off, you're saying, wait a minute, whether this program comes or goes, we have to take care of our patients. And this is our regular routine. Now, how do we layer this over what we do now and do it better? So that's what we're doing. So what we did was that we broke this into 3 parts. It's actually an unending cycle, but we just broke it into 3 parts to make it easy to walk through. So the first phase is before the office visit. What are the things that happen just before the patient shows up for the doctor's appointment? So we discussed some process steps that take place here, and we would call out and highlight the requirements in the different primary care functions. So you know, oh, I just actually touched on empowerment. Oh, I just touched on risk stratification. Oh, you already do these things. So let's not look at this like a test that we have to go checking boxes, but let's kind of see how this aligns to what we currently do. The second phase is during the office visit. So now the patient is in the office. What are the steps? And again, how does that align with the model? And then post-office visit, when the patient is done with the office visit, what are the things that can happen? And like I said, that comes again full circle. So if you look at the structure of that table there, you have the first part, which is the process step. So it will talk about some processes that occur just before the office visit. And when I say just before, I'm emphasizing that because we could have talked about episodic care management here, but we chose to talk about that just after the office visit. So if I say just before, it's just, okay, patient is showing up tomorrow, right? Or in 2 days. Here you have the owner. So these are the combination thereof of the practice staff you have. And we have this in small, tiny acronyms. And if you look at the top of your chart there, you see what the acronyms or the abbreviations stand for. So you have the nurse, so you can adjust this to what your practice has in terms of people. Then these are the technology and tools that you need for that step or that process. The EMR, if you need call scripts, if you need practice criteria or protocol and things like that. Why is this important? You need to know that you need to have certain things in place to be successful. And most times you have practice staff who know what they know and it's all in their head. But it's important to also have what you call a manual of how we just do work here. It doesn't have to be as detailed, but it's like a standard or baseline so that as people have to take a break, people have to back again, it's team-based care. So you may not be there all the time, but the team being there is what we need. So having a place where we can save our processes and how we do what we do gets everyone on the same page. And if in the future, this program expands, another program comes, and you see the need to change or update something, it's always easy to go back to something that you have already kind of outlined, instead of saying, by the way, how do you do what you do? And it's all in someone's head. Now, despite the fact that we walk through the steps every day, we know the people who are doing this, we have the technology and tools, what is most important is what is the patient's experience. You may be a great practice, you think you're doing a great job, but if your patient don't feel that this is a great experience, then what's the point? So we will capture the patient experience throughout this, and these are things as simple as I was able to send messages to my care team on the portal. My CHW reached out to me to complete a form for housing for me. So these are the simple status, this small satisfaction here and there that kind of add up to the patient experience. So we want you to think about, as you walk through the process, identify who's doing what and all the technology tools and whatever that goes into it. What is the outcome? What is the outcome in terms of the patient experience? And how is that aligned to the health outcome? So this is our test patient, Mr. Nexa, this punky 71-year-old Medicare beneficiary. We have her profile here, and we try to cover as much as we can, so throughout the sessions we can keep referring back to that. So we have her clinical profile here. She is a type 2 diabetic. She has long-standing hypertension. She had a congestive heart failure following a heart attack 3 years prior. She had a hip fracture, so she's on opioids. This is a social profile. So when we come to session 8 or 9, I believe, to discuss social needs and social determinants, we look more into what her social profile looks like. Personality and behavior profile. We need to know what's her personality. You know, you have some people who always kind of you have to be more careful when talking to them. Oh, they're just more extroverted or introverted, so things to keep in mind. And then we look at her utilization profile in the last 6 months. ED visits, she had 5 ED visits, 2 hospitalizations. And the most recent hospitalization was for uncontrolled CHF. And then we look at her cost utilization. As you know, this is on the MDPCP dashboard or the CRIS portal to see what's her cost in the last 6 months, so we can see how all the work we're doing is impacting the cost of care. This is our test practice. Again, we just have this up here, but we'll keep talking about the variations thereof in all the steps, whether it be a small practice or a practice that's affiliated with a system. This is modeled after our practice actually in Glenbury. It's independent. They have 4 practitioners, 1 PCP, 1 nurse practitioner, 2 PAs, a support staff of 6, 3 MAs, 1 LPN, 1 office manager, and 1 assistant office manager. Number of MDPCP beneficiaries is about 800, but they have 8,000 patients. And the mysterious doctor is Dr. Links. Okay, so I will be tagging with Ashley Johnson. She is a lead community health worker for one of the CTOs in the program. We do not have any disclosures related to this presentation. So in phase 1, before the office visit, the key steps we're going to touch on is prior telephonic or in-person contact made with the patient. Was the encounter with somebody on the care team? So it's somebody who knows the patient, continuity here. Was the encounter documented, close to real time? And this would touch on 2 requirements, empowerment and continuity, that the patient has continuity because they keep having encounters with folks on their care team who know them. And 24/7 access, that's also a requirement. So the fact that you're able to have access to the patient information at the time you need to and be able to document, that touches on that. The second step here is appointment scheduling and reminder calls. Is the patient scheduled to see an assigned PCP or care team? And any pre-appointment questionnaire that you think might be helpful. Again, we're touching on empowerment and continuity. To an extent, some people get the AWVs, send AWVs out as a pre-appointment questionnaire so patients can come prepared with answers. Some choose not to. And then the third process is prior visit data reviews. So this is happening independent of the patient, where you have reviews of the patients the patients that are scheduled to see the PCP or the care team that day or that week. And then you do a routine panel empanelment optimization, looking at patients who have passed away to make sure you update that. You have a new physician who came in and now you need to adjust those records in the system and things like that. For data reviews that you do, This again will touch on your empowerment and continuity, data-driven improvement, data-driven care improvement, and re-stratification. And then we talked about, someone already mentioned this for team building. We will talk about pre-visit huddle, and then the frequency. Do you do daily? Do you do weekly? And the agenda. What's your agenda? How do you do this? So the session objectives here is to walk through the following concept of what happens just before the patient comes for their office visit, phase one. So we'll look at workflows, people process technology and tools, interdisciplinary teams and care team roles, team huddles, EMR tools for empowerment, there's tools for re-stratification, minimum data sets required for handoff. What do I need to know before I hand it off to the next person on the care team? And proper and secure documentation for each transition. Okay. So please, again, answer the pre-survey questions on topics 8 to 12. And now we'll go ahead and play this video on the value of team-based care.
This is a time of tremendous change in healthcare, and change can be really scary. But it's also a time of great opportunity for transformation.
Everybody's familiar with the problem of rising healthcare costs. The rising costs are a big challenge for the federal government, for state governments, for families and businesses. But what also needs a lot of attention are the gaps in quality in our healthcare.
The most tangible way to fix our broken healthcare system now is really to put the patient at the center and to actually meaningfully structure the team and the delivery of care around that patient. Frontline workers in health have an enormous role to play, and when they are recognized and incorporated in a meaningful way in these teams, they become extraordinarily powerful workers. So, for example, at High Plains in Colorado, they have integrated medical assistants onto the care team to pretty high levels. They're using ratios of 3 medical assistants to every clinician. And with that sort of a team, they're able to provide much better care to their patients and increase productivity significantly.
We're able to provide almost 30,000 visits per year because we use nurse practitioners, we use physician assistants, and we surround our providers with well-trained patient facilitators and the health coaches so that our providers do only the things that nobody else can do.
It's a different approach to healthcare. These patients have to be involved and educated in taking care of themselves, and the staff needs to be able to provide that education. So in order for them to do that, they have to be trained on an ongoing basis. That is so important.
I felt great working at the Union Health Center and knowing that I was going to be able to do more than just medical assistant, that I was able to move up in a career ladder.
We're talking about having roles redefined in a way that helps everybody get their jobs done better.
Support is a very important piece of working in healthcare, and knowing that you have a team, so it's not just one individual, but multiple people who are all geared toward the same goal, makes a big difference in keeping your own motivation up.
In places like AtlantiCare, the team-based approach to care means relying on other professionals, including medical assistants as well as nurses, to deliver care.
There isn't a divide here between the MA and the doctors or health coaches. We all here as one. We respect each other. You know, we did it as a team.
In addition, they can provide a lot of services that just went by the wayside before because they were thought to be too expensive.
The point of it is that everybody on the team has a stake in each patient and a stake in the outcomes of that patient. So the team is there to help each patient get better, one patient at a time.
I knew intuitively that it would be a success, but it was not a proven concept. So because I'm a nurse by background, it just felt like if you did it right, you would get the outcomes you set out to do.
Sometimes people say that it sounds like it's too good to be true, but you can do this in any city in America, focusing on the patients with chronic conditions, improving care and reducing costs.
So hopefully you saw, I guess, a snapshot of people who have tried team-based care and the outcomes that they've seen. You see that this improves the healthcare outcome. But something they mentioned that was very important, that everybody, first of all, bought into the idea that this is a good structure to have with team-based care, and everybody on the care team felt respected, that they matter. So hopefully we can have all our practices here join this group of folks who have already taken the lead here to implement in our own small way. And I also like the nurse who said, I knew this would be hard, but if it's the right thing to do, why not? It may take us a long time to get there, but we know we're on the right track. So something to consider as you embark on establishing your team-based care structure. So why is this important? It's because you can deliver comprehensive care. My grandma always told me, you may be taller than me, but you're sure not shorter. I'm better at being shorter. So that's the truth. The practitioner cannot be as good as a CHW in addressing social needs. Neither can they be as good as the nurse who's trying to coordinate care. So again, having a comprehensive care for the patient really is dependent on the composition of your care team. Increase productivity, improve healthcare outcomes, decrease costs and healthcare savings. I want to pause here to say this. Because I've been on the payer side and the provider side, you have to choose your words wisely. You don't meet providers and start talking about cost savings. They didn't show up from business school. They had a clinical education to save lives. So when you talk about healthcare outcomes, now they're paying attention. The truth of the fact is, if you take care of your patient the way they should be taken care of, you would actually save cost. So when we meet with providers, we try to say, ultimately, we want you to know that your actions here has this impact, but we cannot make that the first message because that's not what they're here for. But it's good to know that resources finite, unfortunately. We always want more of something. We never have enough money for everything. So being aware of how we can use the little we have to do the most we can is important. So to the extent that the conversations around that is helpful, but I just want to say that if we keep talking about reduce cost, we are clear that if we focus on quality improvement, healthcare outcomes, will ultimately reduce cost. Increased patient satisfaction is another thing that you see with having a team-based structure. Effective collaboration and use of resources, satisfaction amongst team members, and improved patient safety. This next slide actually just shows that you may have the primary team at the core. These are the folks who touch the patient, who have encounters with patients more often. But again, as we said, there's an extended team. That could be the CHW who they need once in a while, the social worker for only those who have behavioral health needs, maybe, or social needs, health coach for those who need to be on a diet, addressing their nutrition, a diabetic educator for your diabetic patients, and things like that. So we have a breakout session, and you need to choose the face that best describes your confidence level with being in an interdisciplinary team or working in a team-based care structure. So I'll go to the next slide, and hopefully.
Now for this one, you actually have to go to the website. You won't be able to text an emoji to show up on here.
So if you just want to click on the emoji, so anyone there yet? Can you see it? Okay. So some of you have a great experience with team-based care. Some close to that, some come up. But nobody who already does team-based care thinks that this is a bad idea. So let me reach out to one or two of you here who selected this emojis. Okay, show of hands. Who has a great experience with team-based care? Can you share with us what your experience has been?
Well, it gives each person in the team the ability to practice at their highest level. Really?
This is a first.
Absolutely. I feel that it gives each person in the team the ability to practice at their highest level, and it gives them the feeling that they're important to the team and what they have to contribute really counts.
Okay, can you share more about the care team structure in your practice? So what does your care team comprise of?
Okay, so we work in care coordination, so it's a little bit different. We work within the practice, but we have MOAs, we have nurses, we have physicians, PAs, nurse practitioners, and the care coordination team who works with the patients outside of the practice in between the visits in order to help the team make everything go smoothly when the patient gets there.
We also have a partnership with Wilson County Health Department. So we have a community health nurse that can go into the room and do assessment, med reconciliation. We have our community health outreach worker, our child, and then a social worker as well. In the ED, we have our we have 2 case managers, but we also have substance abuse, addictions, social worker that's available that we'll give direct referrals to. We have remote patient monitoring, nutrition, and diabetic education as well.
Wow. So do you have a CTO you work with?
We are the CTO.
You are the CTO. Okay, I was gonna say this practice is growing.
It's a little different because underneath of our umbrella, we have multiple practice sites. So, and then we have a couple independent private sites that are under that umbrella. So it's just a little different model.
Great. So I think what is refreshing for me to hear is that this CTO comes prepared. So by the time she was going, I'd gone past my two palms of my hands. So easily 12 different roles for care coordinators to providers. And this is the truth about how we can make team-based care happen. We need to identify these different roles and have them ready to understand how best to apply them. Now, for practices that have maybe just a few folks, some folks, like I said before, wear multiple hats, but I think it's understanding the baseline of what are the key care team members we need to have a sustainable, effective, successful team-based care structure. Now, that is a separate question from do we have the resources? So sometimes we just work with what we see and it doesn't allow us to think about the big picture. But sometimes it's good to not look at what limits you now and just ask the question. Because now when you say, okay, fine, and we have this, there's a gap here, there's a vacancy here. And then if you have a CTO to work with, you're clear about what you need. You're clear about where to start the conversation. And if you do have some monies provided you to invest in, you've already done your homework. So keep thinking about that and say, because every practice will be different. And then some things may be too much for you to bear. For example, you may not be able to have a nutritionist on your payroll. But if you have a CTO that has that, then that's where that resource is. Or you could partner with someone who has an independent practice, and you just refer your patients, and then you just have a collaborative with that particular specialist or provider. So again, but being clear about what are the resources I think I need in my practice to help me take care of the patients, and then identify what do we have in place, what we don't have in place, and how can we bridge the gap. Thank you for sharing. Okay, so going back to our test patient here, Ms. Anexa, again, just reminding you of the clinical profile as we begin going through the steps. Okay, so as we talked about the first step where we're going to talk about prior telephonic or in-person encounters, the first thing that the care team encounters with the patient could occur in multiple ways before the next doctor's visit. And that is what is being asked of you for 24/7 access. So whatever it is you already do, you already can check that box. Now the question is, can we improve on it? The next question you may ask yourself is, what percentage of our patients are using these alternative options for access? And see how you can improve, encourage. And we also need to ensure that Ms. Anexa is empaneled to a care team to promote comprehensive encounter. And again, this is touching on empowerment. What is the experience? And this will be in blue. And she shows that she's happy to have access to members on her care team, and they contacted her before our office visit. I matter, they see me, they're engaged. The workflow here will capture things like your practices process for empowerment. We've gone through that already. We've done a PDSA example of that, and responding to questions on the patient portal. What is our protocol? If a patient asks a question, should we leave that to the, in a practice that has at least 2 care teams, do we leave that to the assigned care team to respond to? And then do you have a standard way to respond to certain requests? Medication on refill, you know what to do in terms of putting it in your EMR and pending that till the physician looks and see, no, I need the patient to come in before ordering another refill and things like that. So two things here we want to touch on from a requirements perspective is the empowerment and quality improvement. So again, knowing your why. Why do you empanel? It promotes continuity, it builds trust, and promotes better health outcomes because the care team knows the patient. It provides provider satisfaction, patient satisfaction, and facilitates panel-level population management. The reason why I'm spending just a bit more time on empanelment is because at the end of the day, taking care of your patients depends on resources. So if you're not seeing empanelment as something beyond, oh, she sees Dr. A or she sees Dr. B, then you're missing the goal. So you need to be clear on how many patients do we have and who is assigned to take care of these patients. And if we want to improve health outcomes, do we need more of, less of? So please think about that when you think about empowerment. So this is example A. It's a much more simpler practice. They have one physician, one NA, one front office desk staff. The steps to take, as we have seen before in the workflow, identify who your active patients are. This practice used to do a 24-month look-back period. You also have your MDPCP dashboard to leverage to do this, as well as your EMR, and then empanel the patients. And we've seen provider-patient ratio. If this is one PCP, there's nothing you can pretty much do about it. If there are 2 providers in the practice, then you can choose to do 50-50, 60-40, whatever makes sense. And then assigning high risk. Maybe in this practice, it's just one PCP, so everyone's assigned to the PCP. But if it was, if you had 2 PCPs, you could say the high risk patients were assigned to the MD, but the rising and low risk patient were assigned to the PA. So things like that. And then you empanel the patients, and then consider reviewing that every year, bi-monthly, whatever works for you. And then you also can measure and optimize continuity. In this practice, it's easy, it's one of everything. So it's easy to assess because of the care team composition. What I want to point out here is your extended team. If you're such a practice and you have a CTO, they may be able to provide you the data analyst, the care manager, and the question is identifying how these guys also will be assigned to the patients. So for some of the CTOs I know that work with practices, it's also, if you go to the patient's medical record, you also see the CTO RN manager's name on the field saying that she's part of the team as well. And this is just an example of a much larger practice and how they may choose to do this differently. Like as I said, the MD will be assigned most of the high-risk patients, and then the remaining 10% will be to the PA or the NP, but all other medium or low-risk patients will be assigned to others. And then here you can see that the method for reviewing continuity will be provider-centric. As simple as pulling the information from the EMR to say, of all the patients that this provider saw, how many of them were impaneled to this provider? So you get to know how often that happens. Now, it would never be 100%, I believe. If you see IHI is about 70 or so %, because you have to, know the physician will take a break. Sometimes things happen, but you have to make sure that at least you're on top of it to see that majority of the time the patient is seeing the care team that they're impaneled to. And the good thing, again, if you see that icon, this is something you report out on your quarterly report. So this is something you do. You're able to not only check the box and say we do it, you can, sometimes they have comments underneath there. Did the CTO help you or not? And you're able to identify how they did help you. Did they help you by providing the resource, or did they help you by thinking through the steps you should take to have it in place and review? So based on Ms. Anexa is assigned to a care team, an MD, an RN, and a support care manager. Go ahead.
Quick question. For when you're looking at the lead CM care manager assigned, the lead CM assigned all high-risk patients up to 2,000. What is the touch for that patient?
Good question. So this is the only number that was released by CMS, for those of you who know. And it's been a very fine dance, and I will have Ashley come and speak a little bit more about what is being done in the CTO. But to your point, that all depends on the care manager, because the fact that they're impaneled to 2,000 patients doesn't mean that they all have the same level of priority. So now, this is the way we see it. And for the nurses in the room, you will appreciate what I'm about to say. The nurse sits at the head of care coordination. Please do not proceed without them there. Be the nurse lead RN from the CTO or the practice, they need to be empowered. We've seen examples of CTOs providing lead RNs who are not empowered. It's almost like they show up as a guest and get out. But they are supposed to lead something, but so far they're leading themselves. So they need to be at the top, and therefore you can have 2,000 patients in their panel, but to support that nurse, you have the MA, you have the lead RN, and now you have some MAs that are that well-trained or advanced that they are lead care managers. But when you have a lead RN, which is a requirement, most CTOs have their lead RNs to be lead care managers to be RNs. That lead RN has the support of the MAs. They have the support of other care coordinators and the community health worker, and they help guide what's going on. So for example, the way we've seen it done, you start with the attribution list and look at the high-risk patients and patients with complex needs. Now, the lead RN is supposed to assess the patients to see if they need longitudinal care management. Once they're assessed, then they have to have a care plan in place. Now, think about it in that ratio. It will take quite a bit for that one nurse to go through 2,000 patients. But at least if she has a plan, at least if she's supported by that being already embedded in the EMR, these are things that she can actually begin to kind of pace herself within the year to make sure she touches most of them. Now, that said, while this is going on, there's episodic care management happening here. Folks are going to the ED, coming out. Now, that's a separate workflow. The first line of support for outreaching the episodic patients who have a recent ED visit or hospitalization should not be the lead RN. She should have support doing that, but they escalate to her as soon as there's a clinical need for follow-up, because that's what she's there for. So she can plan in her day time for doing her routine LCM work. I have patients who I already assessed, they already have a care plan, I follow up with them, I'm making sure that they go to their diabetic, they have the diabetic education, if they have self-management goals, we talk about it. But she also carves out some time for those escalations in terms for patients who might need to have further explanation for discharge instructions and things like that. So it will take the team to understand her role, to empower her by making sure she has support so she can delegate as needed. And then she can actually feasibly have that 2,000 panel because she has a way to kind of, and then, for example, if she's trying to reach a patient who's already enrolled in LCM and she's not able to reach the patient, she should spend her time trying to make phone calls. So she makes 1, 2, she delegates it to the CHW, say, hey, can you reach out and see what's going on? So, but she needs to be that empowered. Otherwise, she'll just be checking boxes and never get around to, formally do this. Now, over time, it might well be that the ratio 2,000 to 1 doesn't quite work. Maybe 1,500. So again, it's up to the practice to look and see what works for them. But they're just throwing things out that they've seen other people experiment with and had success with. But it's not just saying and lead RN to 2,000 patients, end of story. No, she needs to be empowered as the lead to delegate, and therefore she can prioritize as needed. Does this help? Okay. So how many of us have similar empowerment processes, and does anyone have something different they do besides what we have already described? Anybody do something innovative, creative outside what we're doing? No? Okay. So step B in phase 1 is I'm looking at appointment scheduling and reminder calls. Permission and access schedule for a doctor's visit in 2 days. And the visit type is established patient follow-up. These are normally color-coded depending on the EMR you're using. This again is trying to ensure continuity to make sure that they schedule the patient with someone on the care team. She has received reminder calls from her doctor's office, and she also received a text message to confirm that she'll be attending, and she did confirm. What is her experience? She is happy with the number of reminders that she got and the details about her appointment, the time, when, and if anything she needs to bring with her. So this is an example of a scheduling template. As you can see, it's color-coded, and appointment types could include follow-up visit, illness, lab, or new patient. So again, it's nice to have these so you are aware of access. You've heard of the double booking, triple booking, all the bookings. Again, you have to keep, is a trial and error till you find that sweet spot, because you have to make accommodation for no-shows, which averages about 20% for, but could be higher depending on location. So things you should keep in mind. So I'll reach out to Ashley now just to share in general what she's observed, the practices she's supporting, and how they try to share reminders and do reminder calls, for patients.
Good afternoon, everyone. So a part of the CTO that I'm with and the practitioners that we work with is a very small practice. There's 2 physicians, about 4 to 5 staff members. And what we do is we have an automatic phone call to remind patients of their appointments. If they do not answer, we do leave a voicemail, but it's followed by a text message. And I think it's important to recognize the preferences of all of our patients. Some like receiving phone calls, some like receiving the text messages, but they also like the human touch as well. So we do one more phone call, and that is either from the CHW or the care manager or someone from the front staff, if they're available, to just say, hey, you got this follow-up appointment, or hey, you were just in an ER, a couple of days ago. It's really important that you get to your appointment. In those conversations, they're normally very happy to hear from a live person, and then we may find out other things. Oh, I don't have transportation to get to the hospital. So then the staff member will send me a note in the ER saying, can you help Mrs. Smith, Mr. Smith to get to their appointment? It's really important that they get in. So it really goes back to a team collaborative approach to, if we're all working together and we're all talking together, we can figure out how to best get the patient into the doctor's office to see the doctor. Something else we just started is the patient portal. So if someone wants to schedule an appointment, they can go to the website, if they have access to the website, and they can say, I want to see my doctor, fill in a really quick form, first name, last name, and a date that they prefer. It goes straight to the practice, and the practice can follow up. And then they'll get a text message that says, we received your request. Someone from our office will be in touch with you shortly. So I think the constant communication really helps, I guess, the turnover and people not canceling appointments and not missing their appointments. So I'm interested to hear from you about if you have a similar process. This is the Medicare demographic, but what do they prefer? What do they like? What does your practice do? Any break? Yes.
We fill all their meds on their appointments, so they know how important it is to make that appointment. So we have a high, I'd say it's 90%.
That's awesome. So accountability, they have to come into to the doctor's office to get those refill requests. Right. Anyone else? Anyone do anything differently? Okay. All right.
Thank you. You might want to sit over here so you don't have to walk to the car. Thank you for that. So you see, I set her up. I said, you help here. Okay, and then for step C, we're looking at prior visit data and report reviews. So the care team will review different patient panel reports. Some are generated or populated in your EMR, and some are on the CRIS portal. Whatever the case may be, you may choose to look at disease specific, because a lot of people like to teach or work towards the test. So we know we have diabetes or hypertension, so you already have practices who are addressing this cohort of patients to make sure that they look at those who are there, making sure that they are being assessed for LCM and seeing if they need self-management and education support. So this touches on data-driven care improvement, that's function 5. And the experience here is, if you see here, it's kind of blurred out. And what we're trying to elicit here is the fact that team is actually looking at data and reviewing data, which could include the IT folks or the data analysts as well, is that this action that you're doing now has an ultimate impact, but you may not see it right away. But it's important that people say, how do I contribute? How do I contribute to the bigger picture? Now, when the doctor gets to see Ms. Anexa, he's able to, or she's able to communicate her progress very comprehensively. He's able to say, I know you went to the ED, I know you had this done, I know the CHW reached out to you. He's able to just have a more in-depth conversation, like, oh, he did his own work. So, but all that happened because you review data together, probably have a pre-visit huddle and things like that. So also looking at the attribution list and current risk scores and trying to see, is this patient high risk or low risk? How has that changed? We'll also talk about this in detail. So we'll talk more about risk stratification in the next slide. So risk stratification, knowing why. Why should we risk stratify? It provides an actionable view into the needs of your patient population. You're able to know who needs more help and when. It targets resources to your patients who demonstrate the greatest need. It supports your effort to address care management needs of high or rising risk patients. Why do we focus on episodic care? Because that might be a patient that's a rising risk to high risk and gives you an opportunity to intervene before it's too late. It also supports your effort to address preventable care needs for your low risk patients as well. So you have the screenings that are done. It's not really a focus from NDPCP yet. I would say for the national version of NDPCP it is. So all those screening for colorectal cancer, breast cancer and things like that. It also helps you provide those preventative care services for your patient. So risk stratification, we have the algorithm, step 1 for the risk stratification. Now, prior to NDPCP, folks have done this differently. It doesn't really matter. We just need to know that the data that you use to populate the algorithm score is based on diagnosis, claims, And there's a variety. We would advise that you use what is provided for you through CRISP, and it just kind of takes off a lot from you. The only thing will be for your patients that are not MD-PCP, what you currently have in place that kind of help you align. And please note, as I speak to you, I try to talk about MD-PCP specifically, but also try to make it more general, because when you show up to work, you don't want to look at a patient and say, okay, you are MD-PCP, not MD-PCP. So you really want to have a more holistic approach to your care delivery process. So to the extent that we can say, hey, this might be things that are specific to MD-PCP, but see how you can actually extend that across the board. We'll do so as well. So you can leverage the CRISP data, utilization and cost, to see the risk strata of your patients, and that's updated monthly, regardless of which method you use. For the algorithm or the first step. These are the key components. You have a predefined risk based on claims. You have a component on utilization, recent ED visits, hospitalization, and then you also have clinical data points, behavioral health, active chronic conditions, active cancer, in the demographics we're working with, dementia. So based on the different intensity of these components, you can now group them into high, medium, and low risk. So this is something simple. If you want to come up with yours, there are some examples that have been shared. I think from the first one ever was from a Mercy clinic, whatever. Some folks like that, some folks did not. So you can make it your own as long as you apply the same rules across the board. And when you think you want to modify or update that, you can. We will also show you, if future slides, and I'll come back to that, some folks use the AAFP tool, so that may be already configured in your EMR. If I would say that some practices we had worked with had that there, they didn't know it was there, we're not using it, so they have to now develop training for providers to say, okay, you already have this, you might as well use it. Okay, so and then you have to apply clinical intuition, because sometimes all the information is not captured, right, in the data. Claims data. So other the components that would inform your clinical intuition includes the patient's social needs, health literacy, activation, family and caregiver support, and behavioral or medical need. I will also ping Ashley again to share with you as a CHW how sharing updates on social needs kind of inform the team on how they would adjust the patient's risk strata.
So at our practice, we adapted a form and assessment tool that was actually on a webinar that MD-PCP did. And we basically broke it down to 14 questions to kind of ask some basic social, clinical, and safety needs about our patients. And what we did was we made copies, and it is a work in progress, but we made copies at the checkout station, so all Medicare patients, please fill this out and then take it with your doctor to discuss. We assign scores to each of the questions. So if it's a clinical need, it got a score of a 3. If it was a safety need or concern, it got a 2, and then 1 if it was a social need, because that can then help prioritize the patients. Everybody might have needs, but then whose needs are most important? They all are important, but maybe access to the proper prescription, or maybe a sign of depression, maybe a little bit more on the priority list versus transportation. So while we understand that the needs are there, this tool is bright. It's a one-pager. It's bright. It has my phone number on it. I say, if you have any questions, call or text me. Again, trying to meeting their preference of how they want to communicate, but to know, to kind of let them know that we're here for them, and we are a part of the care collaboration with their physician. And when they take that assessment to the doctor, they can kind of talk about some of those needs while they're in the room with them versus handing it back to the front staff. And, it's a very personal assessment, so you don't kind of want it all over the place, 5 different people looking at it. So that's the approach that we've taken. And in the week 1, we got about 10 assessments filled back, some really interesting needs and immediate needs that need to be addressed right away. I want to say out of the 10, 8 were MD-PCP patients. So that was really surprising. I think we were concerned about the workload, how many non-MDPC patients will we have? But it's really working well, and that priority list is going to help us to kind of prioritize what needs to be done at the huddle. Can the CM take care of it? Or if it's something, if it's a safety need, they don't feel safe at home, then maybe we need to get other agencies involved. So I think that is what we really wanted to achieve. And then at these huddles, we can really talk about how these social needs can impact their health. So if they are feeling unsafe at home, of course you're not going to be feeling well, or vice versa. I'm not feeling well because I don't have my prescription, I can't afford it, therefore I'm lacking in other needs. So I think that's really important. Anyone was on that webinar with the social unmet needs? You were, okay. Did your practice have a similar assessment, or did you adapt anything that you learned from there? Not yet, okay. Anyone out there already have an assessment? Okay, is it in the EMR? Is it a separate sheet? And what kind of questions are on there, if you don't mind? And who takes, so once that's returned, who's the first person that looks at it? Okay. So every year. So we talked about that, just making sure every year gets updated, because needs change in some months, maybe not every year. But so we're trying to also figure out the best way to make sure that gets updated in a very, and language matters as well. So kind of what you're saying on the assessment sheet is also really important.
And also in conversation with you, Ashley, you also mentioned that one patient had actually checked that safety was a concern, but in the question it says, would you like to be contacted by CHW? You said no.
Yeah.
So we were thinking, okay, would it be nice to kind of look for the next patient's doctor's appointment and have CHW be in the office?
Right,
and
for
say, hey,
access.
if you don't mind, there'll be a warm introduction from the doctor to the CHW. Say, hey, just in case you want to talk about social concern, transportation and stuff, just spend 5 minutes with her, and then you can, tap into that, because this may be an elder who's going, or senior who's going through some abuse, that's scared to say, but they were bold enough to check, I have a safety problem.
Right.
So.
And it goes back to trust. A lot of the patients, most of them trust their physicians. So why not talk to them about what my concerns are and who is this strange lady Ashley calling me from this 202 number? So I think if they do the warm handoff, it really helps them think about this as a team effort, which is a new concept. And I don't think they really understand it. But the more they hear our names and the more the physicians are willing to say, they're here for you. Let's work together to make sure all your needs are met, it's really going to make a difference.
Yeah, and back to the slide, we talked about that team-based care needs an initial investment in money, in time, but you benefit from that in the long run. So the physician may just need that one-time warm handoff. The patient feels, okay, I'm associating this trust with my provider with you, and then it becomes smooth sailing from there. So
right.
To think about.
Okay.
Thank you, Ashley.
Thank you.
Ashley, is there a way to get
Go ahead.
that copy?
Yes, so I can provide it to Dr. KK and or Angelica, and I can make it available. I know at one point they asked if we can upload it on the Connect. I don't know if you have access to that. No.
No.
Well, we can
Okay.
I'm gonna get her. We'll get that.
Okay. Or give me a card and I can send you.
She's your patient now. Access 24/7. Just okay. But if you have your email address, then you can give it to Angelica, just to have that that I guess benefit for being here in person. We will go the extra mile to make sure that you get it. Okay. All right. So based on Ms. Annex's profile, she has utilization of 5 ED visits, 2 hospitalization in the past 6 months, a recent hospitalization. She's type 2 diabetic, long-standing hypertension, congestive heart failure, and dependent on opioids. Based on this high level criteria, she's high risk. So it can be as simple as that. But again, you can get, have more comprehensive or in-depth risk stratification methodologies like the AFP tool and all whatnot. So just do what works for you. So I would say also for risk stratification, let's do a PDSA example. Again, trying to throw in PDSA here and there so that it becomes more real for you, how this can be done. So the question here would be, how can we be sure that we're capturing the most appropriate patient risk levels? And the test of change here is to create an efficient risk stratification process to capture our panel patients. So what's the plan? We will identify the risk stratification criteria and who is going to perform risk stratification. So we will risk stratify the panel patients using the CRIFS data first. We do the low risk, medium risk, high risk, and then we'll also take a second step to use social determinants, maybe feedback for the patient's social needs, look at the clinical information. Sometimes the physicians or the providers and the nurses know offhand what these are, and these are also secondary sources of identifying risk. And then we'll study how do the two risk stratification sources compare when used alone. If we only use the CRIFS data or the attribution list that was first sent, which a lot of people are doing, if you have that and just say, let's just review the top 20, adding other data sources and clinical intuition. Did it change? Was it the same? So that you can be more informed. And then the number of impaneled patients without the CRIFS realization that you eventually had to stratify as risk, bump them up because you had a better insight from the data from social determinants or social needs, DMR, and clinical information. And then the number of impaneled patients with high risk realization that have not had a visit in the past 3 months. And after studying this, you say, you figure out that there was significant difference enough, and you choose to use at least 2 sources to refine the risk stratification process, where the second source is actually clinical intuition informed by data sources like social needs, clinical information, and all whatnot. So again, this is something I don't know how many practices have tried it, but again, you feel that you're running a race against time and just grab what you can, and which is okay. But remember, this is an 8-year journey. So the time to fail or the time to be slow is now, because come year 4 or so, we hope that you should be further along in the process. So take your time to figure it out, and not race to track 2 for those who are in track 1 or those in track 2 to do, we must be here. I mean, so again, something to think about. So breakout session, a lot of us have done risk stratification since the start of the program. Any challenges with risk stratifying that you'd like to share? You're walking through. Yes.
I have found that even though we try to take on the higher risk, 5 or above, every now and then we'll get somebody that, is like a 2, but then they are going to escalate, and if you don't really nip it in the bud or get involved sooner, then they are going to be higher.
So what's the percentage of patients that this happened to, and how does that throw everybody off? Is it a lot or just one of them? Okay. Yes.
And I had the opposite. So we've had level 5s, level 4s. After the long-term care management, we found out, I'm doing great. Life is good. I'm back on my feet. So maybe something we've done has improved their health. So that risk stratifying is really important in making sure everyone's on the same page about capturing that change.
And also something I wanted to, go ahead.
Oh, no, go ahead. Finish the thought.
You go ahead.
I was going to say, back to the risk stratification, I found similar to Gigi where we don't always capture the people who really do have some high risk because maybe they're not checking the boxes we're looking for. Whereas we have set out our defined criteria of, CHF, diabetes, but then we will filter through some people who seem to be lower risk from a numbers perspective, but socially or they're just not reporting their medical needs and they're not being captured in the high risk.
Good. So now I think one thing I wanted to touch on 2 things based on what the feedback you guys shared. If a patient is diagnosed with dementia, they are complex. Yes. Even if they're stable, it doesn't drop them down from high risk. So back to the point of having the 2,000 patients on my LCM panel, is all about priority. But I can have a patient who is receiving longitudinal care management because they are high risk or have complex needs, and they are stable right now. So the acuity of my services, my care services, are low at this point because they do not need an intense acuity support. That does not mean that I keep my eye off the ball or bump them to a lower risk tier, because you already know that this could go off, exactly. So it's good to identify the patient in different risk stratas, but therein the acuity levels at different points in time is different. Go ahead.
I don't know if anybody else is using the HCC scores off of CRISP, but sometimes I feel that you could have a patient that's within that medium to high risk level that you may not realize is actually going through an event and they haven't hit that higher score yet. Yeah, exactly.
So with that said, if you guys heard what her comment was, that when you get the HCC scoring on CRISP and you see a patient who is assigned as a mid-high risk level, that they may be on their way to high risk and you may miss that. Now, I will say that that's why we use every arsenal that we have. So CRISP also has ENS. So that's real time, even though the other report is a lag because it's based on claims. So that's why we have the ENS and we're looking at that actively. So that patient may now have an episode that, and when they do have an episode, the initial outreach is to assess what got you here. And then that gives you an opportunity to capture that, adjust the risk stratification level of the patient, and then assess for additional support that they may need, care management support that they may need. Yes.
I was just curious, our department is about 90 days, follow for 90 days, and then try to discharge them. But it's really hard to discharge some people, so I just wondered if anybody else had that same time frame, or do you kind of keep those Alzheimer's patients on your panel to kind of?
They are. The question again is the acuity. So acuity level is what you're speaking to, which is the 90 days. And I think, let me say this again. Because of resources and not having enough resources, is a need to feel I need to work with them for 90 days as a care manager or as a CHW so I can transition them and open up space for more people. That's one way to look at it. A better way to look at it is saying, again, what are the things that qualify this patient to be labeled, quote unquote, high risk? And what about that is not changing? Right? And then what are the different, I can have level 1, 2, 3 acuity, meaning if they are stable, then it's acuity level 1. We just kind of touch base once a month. We have caregiver, you see what I'm saying? But now this person now says escalate, we go to level 3. But that doesn't make me transition this person out. Now, moving from level 3 to 1 may be 90 days. I have 90 days to reduce the acuity need of this patient who is ineligible, but keep an eye on them, as opposed to thinking, oh, I want to be done with them. Because if you have a patient who has the kind of long-term need, it's more important that you have a long-term care team who understands them, because it's easier for you to drop that acuity level down because you know the patient, as opposed to every time they have an episode or they have increased acuity, somebody new shows up and they have to start the story over again. So something to think about. Any other questions, comments? I'm enjoying this. I'm feeling the vibe here. I'm gonna go sit here and have lunch with you guys here. So I can get more energy. TJ, I'm not talking to you. He glanced at me. So step D, pre-visit huddle, we talked about that. In this step, it builds on the previous step. The care team does a pre-visit huddle, just kind of understand what we need to know about the patient. In this test clinic, the team discusses Mr. Nexus status a day prior to her office visit. The care manager realized, amongst other things, she's now eligible for AWV and also behavioral health screening. So the team will send out a message to notify her that these things will be done when she comes in tomorrow. Because sometimes the patient may plan for being there for 30 minutes, 40 minutes, and then now you're gonna keep me there for 3. You just spoiled my day. So it's good to inform them ahead of time. Even though they will spend this amount of time with the physician, they may also see other members of the care team depending on what is up, what's coming up that's due. So this is also data-driven care improvement. We're able to see the data to let us know when the AWVs are due or behavioral health screening. And then what's the experience? The experience here is that Ms. Alexis, she will not be asked the same question multiple times because she feels the care team is on top of it. So if I have an AWV due, that means it's most likely that you have the old one. So pretty much you review it and you pretty much just walk me through confirm if this is going on, it's not. We will talk about AWV further down the road, but she feels like her team knows her. Again, back to the patient experience. So this is a video to show you what a team huddle looks like.
Are you ladies ready to huddle?
Yeah. Some add-in spots for the day. We could do a 9:30, 11:30, a 2:15, and a 3:30.
That looks great.
And then I will have our scheduler call the 2 o'clock since Ted chronically misses his appointments.
Okay, thank you.
Okay, our first patient of the day is Sue. She's coming in for an ER follow-up. She was seen within a different system, so we will have to get those records pulled for her.
Okay.
And that A1C that we added onto Mary's labs came back and her result came back to a 7. So we could do some warm handoff to the RN for some diabetes education.
Okay, great. Give them a heads up about that.
Okay, Jane, she's coming in for some lower back pain. Then we can see if the physical therapist can see her if she's eligible.
Okay.
And then we have Ed coming in. He doesn't have any insurance, so we could possibly do a referral to case management.
Okay, and if she's available, we'll make that a warm handoff.
Okay. Okay, our last one of the day, Bob, he's coming in for his Medicare visit. He is a candidate for CCM, so we can see if he wants to set that up today. He is our last patient of the day, so we can probably start to see our patients now.
All right, great. And you're going to get that huddle handoff sheet ready for everyone?
Yep, I'll get one to the RN and the scheduler.
All right, thank you.
Morning, ladies.
Morning.
All right, here's a huddle handoff form for each of you. On here, we have some spots where you can do some add-ins. And then Sharon, if you could call her at 2 o'clock, Ted, just because he tends to miss his appointments. And then Teresa, we have our 8 o'clock patient. They're going to be a new diabetic, so if you could do some education at the end of the visit. All right, sounds
Great,
good.
thank you.
Thanks. Paige, do you want to go ahead and start visit prep, and I'll go in and do in basket?
Yeah.
Dr. Rachel, I was viewing results and Mary's glucose came back elevated at 120. I'm going to go ahead and add an A1C.
Oh, perfect. Thank you.
Okay. Looking at our chart prep for the day, Joe is coming in. The only thing it looks like he's due for is his colonoscopy, so we will get that ordered for him today.
Great, and go ahead and schedule it right away too, please.
Bobby Joe's PAP came back normal, so I'll go ahead and message her through the online portal.
Thank you. And Paige, I noticed that Lisa's TSH came back a little bit high. Would you mind sending her a message through the portal that I'd like to increase her levothyroxine to 100 micrograms once a day and repeat that TSH in about 4 to 6 weeks?
All right. We will get that levothyroxine sent over to her pharmacy. I'll get the order put in for that TSH and we'll message that all to her on the portal.
Thank you.
And on Kathy, we received that prior authorization paperwork for her Vibrid. I called the pharmacy already and they will do sertraline. Do you want to go ahead and order the sertraline?
She actually failed sertraline, so if you don't mind doing the prior authorization, I'd appreciate that.
Okay, I will do that.
Thank you.
Excuse me, Dr. Rachel, you have a moment?
Yeah.
I have a patient of yours on the phone, Sarah. She's been sick with cough, chest congestion, about 10 days. I was trying over-the-counter medication, not getting better. Now it seems to be settling more in where she's having a hard time catching a deep breath. I'm wondering if you can see her at all today?
I think all of my double booking spots are filled up. Maybe we can check with Eric.
Okay.
Eric, would you have room to fit a patient in your schedule today?
Yeah, I should have room later this afternoon. Is it a patient I've met before?
Yeah, her name is Sarah. You've seen her in the past.
Okay, yeah, I think I know who that is.
What?
Okay, so use an example, use an example of how this is quick. Normally, typically, it takes about 10 to 15 minutes, but it has to be a care team who understands the patients. So you see they're looking at those who are coming in today, is boom, 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 they need this, this, and that other. And so if you have to do a team huddle that's like 30 minutes, an hour, then we're missing the point, just so you know. So the structure should be evidence, is an evidence-based tool. We show you an example. Used by the primary care team, should occur every day. Some people start off weekly, so take your time, but ultimately the vision, right? The end goal is to have a daily huddle. Have an agenda. It should be less than 10 minutes. You should discuss or call out care needs for the visit. This is what the agenda looks like. Again, for you who have the slides, you see this. So you have who's doing this, the day, the time, who the leader is. Always start by checking in with the team. How are you guys doing, right? And then the agenda review today, identify scheduling opportunities, same day, next day, cancellation. You just saw the physician say, hey, I may not have time, but the nurse had triaged a patient and she said, hey, to her colleague, do you have opportunity to see this patient? And determine any special patient needs for clinic days, if there are care gaps that need to be closed, identify patients who need care outside of the scheduled visit and things like that. And then here is, so this is the agenda, and then this is sort of like a sheet that you check the boxes, new patient follow-up, yes or no, cancel. You can make this your own. As you can see in the example here, they were right in the EMR and just acting in real time. So you can have it that way as well. Okay, so I would have Ashley just share with you her experience with how they do team huddles. I think right now is a weekly thing. So just real quickly.
So we meet with the smaller practice weekly, and they've blocked out the time from 1 to 2 p.m. during their lunchtime. We start with clinical questions first. So if we have patients that need immediate needs, maybe need home health ordered, we kind of start with them. And then we kind of move on to how we can better manage the practice, how we can improve what's working, what's not working. They're really open and they're really able to receive feedback from us. And again, it kind of gives us a team feeling, and we're trying to build a stronger team. We would like to meet with them a little bit more often, but right now weekly is where we are. For our larger practice, it's a little bit different because they're so far in distance, we have to do everything over the phone. And so our care manager and our CHW have to kind of fit around their schedule. So that may be at 7 a.m., before the practice gets started, or that might be over the web. So we're trying to meet the practices where they are and trying to make that happen, but still be present, be there so they know that we're there to support them. But definitely room for improvement. We've been doing this for a couple of months, but we have seen progress in just their response to what we bring to the table. And likewise, kind of what their priorities are. And this person needs a home visit. Can you check on that person? So we gather information from them during the huddles and then likewise. So it's really been helpful to do it weekly. Any huddles out there that you guys do currently? Okay.
Right now, we're just trialing this in one of our offices, and we're getting ready to push it to several of our other offices. But our one office, we have 3 different positions in it, and they do a daily huddle.
Daily.
The one physician does it in the morning, or the nurse practitioner, she does hers in the morning, then we have a physician that does it around lunchtime, and then one does it at the end of the day.
Okay.
It involves, they have the receptionist, the nurse or the MOA. They try to pull in, because we have a specialist in that office, so they try and pull in their MOA every once in a while. And then our nurse, our diabetic nurse, she's also a split role, so
right.
Is involved in the physician. And they, of course, they discuss the patients for the day and which ones that they need to go on to care coordination or to have a little, looked at a little bit more. Don't need care coordination, but or heading that way.
Right. And again, I can't stress to meet the practice where they are. So our small office they're so overworked, the front staff, and so it's really hard to kind of get a huddle together. We don't have the much privacy as you saw in the video. It's kind of just out in the open. There may be a lingering patient, so we have to be very mindful of privacy and things like that. So it again, meeting them where they are and just knowing that we can definitely improve, but that's the key takeaway versus the bigger health system. They all got their own private offices and can call in and talk about things. So, but those are just the differences and just under our CTO that we've noticed.
And something else to add in discussing with Ashley and her team as well is emphasizing on meeting the practices where they are. But remember, in a couple of slides, we talk about foundation. We can adjust what we call standard. So as long as we do team huddle, that's the standard. Now, whether it's bi-weekly, weekly, daily, we're not taking no for an answer, right? We're going to start. So at least to say that for every single requirement helps. Now, I would also say that the providers and or leaders get anxious when they know they're reporting. Mm-hmm. So when you say, hey, the quality reporting is due next week, we said no, yes, last quarter. We said no the first quarter. They're going to think we're not doing anything. Mm-hmm. So now they want to change that narrative and say somewhat, maybe a little bit. So if you remind them that, hey, we have to report on what we're doing, so we need to get something started. Oh, of course, come next week. So use the tools in your arsenals to drive the team, again, towards the objective. Because when people know they're being watched, they try to see how they can bring their best foot forward. But again, meet them where they are. Go ahead.
I have a question. If anyone has, we have a large practice. If anyone has some ideas on how we can be more efficient with our huddles, because we have 7 providers and around 16 examiners. And I think a lot of the pushback that I was getting when we discussed the huddle idea in the office was the fact that when you have 7 providers, they're really restricted on their time in a high volume office, and they don't want to be there for an hour because you have to listen to 6 other people that don't apply to you. So my thoughts in this session today were, what if we huddled, like right now each provider has an MA, if we did more rounded providers, or, you know, I mean, I'm open to a lot of suggestions because I do know that they want to implement some change, but they're a little hesitant because it's so big and it affects so many people.
You're right with thinking what you're thinking and saying, let's identify the care team units we have, and they do their own 10-minute thing. Okay. Why should I listen to a bunch of 9 other that has nothing to do with me? Exactly. So yeah, they should do that, and then you get buy-in. Now there might be need for quarterly, everybody come together, but it has to be more purposeful than just talking about patients. It might be looking at how well are we doing based on the quality report we've done first and second. What is it saying? Which unit or care team is doing outperforming the other, and what can we learn from how they're doing what to improve what? But somebody has to lead the charge in saying, if we have a meeting where we bring everyone together, it has to have purpose, where we're trying to understand what are we doing different that we can do better, as opposed to, yeah, so that would be a good approach. Okay, thank you. Any other questions, comments? Okay, so the question here was, for Mr. Nexa, what data information should be called out during the team huddle for this patient? So again, if you have been following this patient, it would be the fact that she had a recent hospitalization. So we want to call that out. We want to check to see if she has a recent HbA1c and see if that's due. So you have a number of care gaps that you can identify and see how better prepared you can be for Mr. Nexa coming in. So session recap, we discussed care team roles, learned more about how care teams work together, saw some videos to show that, had some live examples by Ashley and some of you also sharing your experience. We learned about the value of an extended and the support teams. We use our test patient, Mr. Nexa, to have a practical conversation about activities that usually occur just before the patient comes into the doctor's office, and reviewed some key requirements on using data to improve care, empowerment and continuity, risk stratification and leveraging increased data, and team huddles. Please take the post survey, and we would go for lunch break right after this instead. And when we come back, we'll do phase 2 and 3 combined. Thank you.